Thank you very much for the kind introduction. So I think we will make a shift now because all of the speakers me and next speakers are not scientists, we are clinicians. And I hope that you won't be disappointed because I won't talk just about the treatment of pain, but I will talk from a viewpoint of a clinician, what is new in the field of chronic pain and how should we treat it. So let's start. Well, as I told you, there is a lot going on in the field of chronic pain. Many views are changing, still changing, and definitely things are not like 20 years ago. So I would like to address this issue. Then, I will mention also psychological and social features of individuals with chronic pain. And in the end, we will speak about the treatment possibilities for the different kinds of pain. Let's start with a new definition that was introduced by International Association for the Study of Pain. I think it was in 2020. That's the old definition. The new definition is not so different. There are some changes in the definition, but what's very important for me that there are also 6 notes that we should see added to the new definition. And they say, the first one, pain is always a personal experience that is influenced to varying degree by biological, psychological, and social factors. And we clinicians know for many years that chronic pain is not the same as acute pain. Professor Abkarian also pointed it out. We know, we see it every day when we treat our patients. And now it's official, so I'm very happy about it. And, pain and nociceptions are different phenomena. That's also what Professor Abkarian said yesterday. We see many patients without any nociceptions, and they are suffering a lot. And there are patients with a lot of degenerative changes or inflammation or something like that, and they somehow cope with this. They are not suffering so much. And through our life, we learn the experience of pain. Unfortunately, we can change it in a positive or also, unfortunately, in a negative way. So we have to use that if it is possible. And if somebody tells us that he is in pain, we should respect it. We are not in his skin, so we just have to believe our patients.
I'm sorry, are questions welcome during the talk as well, or would you prefer?
Yes.
Please.
So you mentioned you have patients that don't have nociception, but they have pain.
Not so much. It started many years ago by the founder of IASP, International Association of Pain. It was Dr. Bonica. He was a military doctor after the Japanese attacked Pearl Harbor. And he couldn't believe that he saw many wounded soldiers with very difficult wounds. They didn't report pain. And on the other side, there were patients, there were soldiers with just minor wounds, and they were really in pain. I'll illustrate it later, Okay? So, although pain usually serves as an adaptive role, it may also have adverse events and on a psychological well-being of the patient who is suffering pain. And verbal description is only just one type of how somebody can tell us that he is in pain. How is it in pain? Just briefly, do we have a lot of chronic pain or not? Yes, we have it. All the studies around the world report around 20 or even more % of pain in the population. We made two small studies, our pain society in Slovenia. The first one was from 2006, and we got the results that 23% of the patients are suffering from chronic pain. And in 2019, I was afraid that the results will be completely different, but they were almost the same, little bit better. So we got the number 22%. And we define chronic pain as pain which lasts more than 6 months and occurs several times a month, maybe 5 or even more. And it is rated 5 or more on the numeric rating scale. So that's the results or the statistic from our clinic. The slide is more than 10 years old. I think that the things has changed now. We have to do a new analysis. But as you can see, most of our patients have low back pain, then headache, and then pain in the cervical region, and then all the other things as well. So, acute pain versus chronic pain. It is not the same thing. I think that even the name is misleading. I would not use the term chronic pain anymore because it's something else. It's not just a long-lasting acute pain. Many things are different, Professor, we heard it from other professors yesterday and today. And if acute pain is an alarm system to protect us, the chronic pain has no physiological function anymore. So it's just it's a mistake in our program, or I don't know how we should call it. And now in ICD-11, International Classification of Disease, we have a new entity, a chronic primary pain. So we always think about pain as a symptom, as a consequence of something. But now we are talking about primary chronic pain, and it's a big shift. It's a big difference. So I'm very happy about it. Okay, we can. As I told you before, I'm not sure. We can see this spine here. It's a normal spine. But I can get such a patient, and he will say, "Doctor, I cannot work. I have back pain. Can you help me, please?" Then the next patient is like this. And she will say, "Okay, I can live with my pain. I know I had many operations, but somehow I can cope it." And that's also a patient that I treated. So just from the picture or MRI, CTs, and so on, we cannot tell how much pain is somebody suffering. New pain classification. Well, previously we were speaking about physiological or nociceptive pain and neuropathic pain. Neuropathic pain is pain which is the consequence of a lesion or disease of the somatosensory system. And nociceptive pain, it's pain according to some stimulation of nociceptors. But we saw so many patients without any injury or disease of the nervous system or nociceptor stimulation, that we couldn't classify them. And we thought that this is a psychogenic pain or idiopathic pain, but now we have a term for it for 5, maybe 4 years, something like that. It is called nociplastic pain. I'm sure that you heard about it, but it's quite new. What's nociplastic pain? It's the consequence of altered function of pain pathways. We don't know exactly what is going on. Some people say that it's very similar to neuropathic pain, but in neuropathic pain we have at least an idea. Maybe there is a multiple sclerosis, or maybe there was a trauma and nervous system is not okay anymore. But if we are talking about nociplastic pain, then we don't know what is really going on. So before this term nociplastic pain, we used to call it functional pain syndromes. And the queen of these functional pain syndromes is, of course, fibromyalgia. There are many, many patients who are in pain, who are suffering, and nothing is wrong. So we think now that they have nociplastic pain. It can be widespread musculoskeletal pain like fibromyalgia, or it can be like just endometriosis, vulvodynia, maybe temporomandibular disorders. It depends. So we have 5 categories: chronic widespread pain and fibromyalgia, complex regional pain syndrome in the limbs. Then we have chronic primary headaches and orofacial pain, chronic visceral pain syndromes, and chronic primary musculoskeletal pain. It's not just pain. Associated features are fatigue, chronic fatigue. They are always very, very tired. They cannot work. The sleep is disturbed, cognitive disturbances, and so on. Quite a lot is going on with these patients. But let's be realistic. I don't believe in these classifications. Okay, I believe in it, but most of the pain is of mixed origin. So if there is an older lady with fibromyalgia, it doesn't mean that she doesn't have a little bit of nociceptive pain because something is going on in her spine.
Is nociplastic pain defined as being exclusive of the others?
No, I don't think so. I think they can coexist.
Like literally in a definition? They say
Yes. Yes, but in real life, you won't see patients with just nociplastic or just neuropathic pain. If you have a man with radiculopathy, it's mixed, in my opinion. It's neuropathic pain and it's nociceptive pain, okay? Because something is going on in the spine, and if the nerve root is injured, then we have both. I think it's logical. Okay, the physiological basis of nociplastic pain is here. It should be central sensitization, and all these things can contribute to the development of central sensitization. Some people say that it is like a knob, and we can switch it off to be the system to be more sensitive, or even to switch it off. So just simple as that. Just in illustration. Then we have neuropathic pain. I told the definition, and the pain is the consequence of when something is wrong in the somatosensory system, and patients report that it is spontaneous, that they have painful sensations in the body parts. Maybe allodynia or hyperalgesia are also present. The attacks may be electrical, spontaneous, and treatment is different than for nociceptive pain. Here are some types of neuropathic pain. If it is peripheral, we can see a lot of these patients. And if it is central, post-stroke, multiple sclerosis, chemotherapy-induced spinal cord injury, and of course, as I told you before, many of these patients have mixed type of pain. So, when we are talking of pain, we also heard that before. We have this sensory discriminative and effective motivational part of pain, and the first one will tell us about how strong is the pain, where it is, in which body part, and about the features. And and this is more the emotional part. It should be older, more primitive, but I think it's even more difficult to treat. But when we would like to be successful in treatment, we should address both types of pain. Here, if I oversimplify it, we have in acute pain, we have simulation of nociceptors, and then we have this emotional component and sensory discriminative component and reaction to this. In chronic pain, this will change. The emotional component will be much bigger. And if we have someone in chronic pain syndrome, these are people who are just living, and pain is the main component of their life, not maybe just their, but their families as well, because they are going from one doctor to another doctor, they are not working, they're just looking for help. And we can see that the emotional component here is huge. And maybe we even don't have any nociceptive stimulation more, because it is gone, it is not here anymore. We can better understand pain if we can adopt this biopsychosocial model, which describes pain as a complex dynamic interaction between all these factors, biological, psychological, and social. So I think that we can much more easier understand our patient if we are thinking in that way. And all these factors are somehow integrated, and they are all very important for the patient, how he will report the pain. Well, I would like to illustrate to you the complexity of pain perception on a story. Maybe some of you know the story because I read a book recently and it is written in a book, but I know the story before. I knew the story before. So it is a story of two nails. And this was a worker in the United States. The stories are true. It is not fiction. And it should be at the evening, he wanted to go home, and there was an accident. He stepped on this nail, okay? You can see it, the nail is quite big. When he saw it, he was screaming, and the ambulance came. They took him to the hospital. They gave him strong analgesics, and then it was a small operation. They removed the nail, okay? It was very dramatic. Then we have another story. It was another worker who shot himself with a nail gun, unfortunately. And he said that it was, it's somewhere here, it was really bad at that moment. But he went home, and he didn't visit the doctor for, I don't know, 5 days. He said to his wife, okay, something is wrong. I have to see my dentist. Maybe there's something wrong with my tooth. And then they made an X-ray, and they saw what was happening. And he didn't have so much pain. They removed it, and I think that he survived. Everything was okay. Just the last thing that I will tell you about this story, he wasn't wounded because the nail went between the fingers. Okay? Yeah. So the tissue was okay, no wound, but he was screaming from pain, okay? Yeah, there are also common psychological factors that contribute to the perception of pain, and we know quite a lot about depression, anxiety, catastrophizing, level of pain acceptance, and coping style. There are many more, just to mention a few of them. And Professor, we heard many times yesterday and today that chronic pain and depression are highly comorbid, and we can see it in our patients. And it is up to 50% of chronic pain patients can be depressed, more in women than in men. And if we are not addressing depression as well, we won't be very satisfied in treating chronic pain. The same is with anxiety. The prevalence is much higher in chronic pain patients. And if we are not addressing it, our outcome will not be so good. So we should treat the whole patient, not the pain. That's our idea. Coping style. Well, it is defined as the effortful, non-automatic attempt to adapt to pain. So I can live in pain, with pain. Some people can do it quite good, and other people cannot, because they say, I can do nothing, I can go out, have no social life, and so on. And more common adaptive coping strategies are quite simple, like relaxation, distraction, positive self-statement, or even ignoring. Some people can do it, but not all of them. But we are here to help them, or psychologists. Catastrophizing. Some people still think that if they are thinking about acute pain, and in acute pain, it's true. If we have a big injury, we have a lot of pain. If the injury is small, the pain is also small. And then they say, okay, in chronic pain, it must be the same, but it is not, because we said that acute and chronic pain are two different entities. It's not the same. And some people will really catastrophize if they have pain, and they cannot believe that there is nothing wrong in their body. They have this find and fix mentality. They are doing visiting many doctors. Sometimes I say they are even operated. Orthopedic surgeons like to operate quite often. And I think that many operations are really not needed. Not just me. I think that all of us that work in a pain clinic have the same mindset. Pain acceptance, well, it's the willingness to engage personal, meaningful activities in pain. Again, some people can do it. And if somebody cannot do it, then it is negatively correlated with physical disability, depression, anxiety, and so on. And this person will, of course, suffer much more. Social factors are also important. From communication and expression, we have to communicate our pain. We need social support. We need support in our family or in school or by our employers and so on. Stigma and judgment. Let's take someone with fibromyalgia. Nothing is wrong. And nobody can see that something is wrong with this person. And he or she can have problems at home, at work. Also, the productivity of this person is quite lower. They are not always working because they cannot work because of the pain. Cultural variability as well, because different cultures have different attitudes toward chronic pain. And the treatment is also different in different countries or cultures. Pain narratives, I like it. Almost all my chronic patients, they have stories why they are in pain. You know, doctor, when I was 6 years old, I had an accident, and when I was 28, it started to hurt, and he believes that this is the reason for his pain. Most of these stories are crazy, but people still like to have them. Healthcare access, of course, if you are poor and you are not insured, then you cannot see the doctor. Media and popular culture can also have a big impact on pain, or not just on pain, on all other things. We are all social beings, and we are somehow influenced by popular media and culture. If we see a movie, a Hollywood movie, and there is someone in pain, I can say, okay, I have the same problem, so it's quite often. I hope that I convinced you that chronic pain is really a problem, because it is not just pain. We have anxiety, depression. People cannot do work, cannot perform their hobbies. They have disturbed sleep, appetite, limited social functioning, and so on. And we have to address all these issues if we would like to be good in pain treatment. So, how should we treat patients with chronic pain? Well, we said we have this normal, let's say normal pain, it's nociceptive pain, then we have neuropathic pain, and we have this new type of pain, which is called nociplastic pain. And there are some common goals of the treatment. We should reduce the pain and disability, of course, and improve function. And with function, I mean physical, physiological, and social function, so that the patient is normally working, that he is active in family, and so on. And this will improve the quality of life. It's very easy to say, but it's quite difficult to achieve. Of course, it's also important that we should minimize adverse events and that the treatment should be cost-effective. So we have non-pharmacological treatments, which are coming back, I think, because as I always say, people also, most of the people, not all of them, like medications, like drugs. Why? There is no waiting list for drugs. I'm at the computer, I can write the prescription, and the patient will have the medication in 10 minutes, okay? So it's just for this pharmacotherapy, there is no waiting list. If he is going to physiotherapy or to see another doctor, he has to wait for weeks, maybe even months, and so people like it. If we can remove the cause of the pain, and there is a cause, okay, that's the best way. But for patients that are coming to pain clinic, we cannot find the cause, or maybe we can find the cause, and because of comorbidity, nobody can operate this patient, so he has to live with this condition, and we have to find another solution. And don't remember, this one-size-fits-all is not very good for treating chronic pain patients. We should make it like made to measure. It's much better. What is good for one patient, it is not good for another. So what are the common treatments for all types of pain? As our former president in Yugoslavia, Josip Broz Tito said, učite se, učite se, učite se, learn, learn, learn. I think it's okay. We should educate our patients, open their eyes that not all of the pain is nociceptive. It can also be nociplastic, so nothing is wrong with their bodies. They just have to know it, to accept it, to fight against it. And then we should tell him about this biopsychosocial model, promote good lifetime habits, which are written here, and so on. Psychological help is also very, very important. Unfortunately, it is not available. People have to wait to see a psychologist or psychiatrist in our country. I don't know how is it in other countries, but it can help. It can help. I'm talking now about patients where the cause cannot be removed, or we don't know the cause, or they have nociplastic pain. If we have very difficult patients, the best way would be a multimodal pain therapy approach. It means that many, not just doctors, also psychologists, also occupational therapists, physiotherapists, nurses, they are all all treating the same patient at the same time. It is better? We think so. Can we help all of our patients? No, I don't think so. But some of them will be better, so why not? It's difficult to organize it. It is not paid by insurance companies because I don't know why, but we should change it. Pharmacological treatment.
A quick question.
Yes.
Who do you think should integrate these multiple approaches? Is that the primary care physician or?
No, he cannot do it. He don't have enough knowledge. I think that maybe, well, we have quite a lot of experience because we are treating pain since our pain clinic was established in '77, I think, or maybe a neurologist who are treating pain on a daily basis. And Uri Socha, as you know, they have such a program, but they have this program just for persons with fibromyalgia. If this person has also real psychiatric comorbidity, he cannot be accepted in this program. And we see a lot of such patients, and they need help as well. So.
Yeah, that's why I asked, because realistically speaking, it's not just that you get treated by diverse experts at the same time, it's that there should be an integrated plan of how
Yes.
modality would fit together.
We are struggling to build such a team. We have now a neurologist, we have a psychiatrist in our pain clinic. Now next would be a psychologist and maybe occupational therapist. So it is going, I hope that we will succeed in next few years. Okay, but something about analgesics, from simple analgesics like paracetamol to strong opioids. I would do a comment on that we are not afraid of prescribing strong opioids, But in my opinion, they are not very effective for chronic pain. That's the first thing. And we are a little bit afraid of this opioid crisis that happened in the United States. So why should we prescribe drugs which are not so effective? Okay, you can have some patient who will respond quite good to strong opioids. But I think that they are a minority. Not all of people who are in pain, now you will get oxy or something else, even morphine, and he will be happy. Maybe for 1 month or 2, then he will say, you know, I'm not feeling very good. And there are side effects, and so I'm not a big fan of opioids anymore. Then we have this secondary analgesic mostly used for neuropathic pain. Also, maybe for nociplastic pain, they can be effective, but we have to keep in mind that if we reduce the pain for 30%, then we can be satisfied. Okay, we won't take the pain away. So that's our goal. And we should combine different drugs because we have different conditions to treat. And we cannot do it with just one drug. So it's good. And I'm an anesthesiologist. And when I started anesthesia, we said we will put a little bit of this and a little bit of that. And it is better than to put just a high dose of just one drug. So it's the same now here. Yes, we would like to be here, few side effects and more effective. That's our goal. We don't want to be here, where we have more side effects and less effective. So when we combine drugs, we have to ask our patients how they feel. Is it better? Do they have side effects? And so on. Treatment options for neuropathic pain. The gold standard are these drugs. Everybody is using it. We can also do a combination, but not with pregabalin or gabapentin, but with pregabalin or, let's say, amitriptyline, because they are different drugs. Secondary choice are these patches, tramadol alone or in combination with tramadol, or many other drugs if we are not successful with this first line. Invasive treatment options, just briefly, we are doing a lot of acupuncture. And I told my friends that some 10, 15 years ago, I thought, well, it's nothing. Acupuncture is, I don't know, it's not good. But now I'm doing many other techniques, including blocks, epidural blocks or dorsal root ganglion blocks. And sometimes you are doing a block perfectly. Everything is perfect. And the result is not here. And then the patient is coming back to you, doctor, can you try with acupuncture, you know? So I think if the patient would like to try a method like acupuncture, why not? And then we are doing a lot of trigger blocks, peripheral nerve blocks, facet joint blocks, not so many sympathetic blocks. Spinal cord stimulation is also performed in 2 centers in Slovenia. They are also implanting intrathecal pumps, radiofrequency ablations, cryotherapy, and then more invasive procedures like dorsal root entry zone lesions and so. But I don't think that that many surgeons are doing them. We have one surgeon, and he is doing microvascular decompression in trigeminal neuralgia. All the other things are quite exotic. Our guidelines for the treatment of neuropathic pain. Well, you can see all the drugs of the first choice here. What's the difference? The difference is that we said, why not to try with acupuncture, with TENS, with psychotherapy immediately? If you think that this will help the patient, you cannot do any harm. And the results can be better. So let's do it. Pharmacological treatment options for nociplastic pain. You can see that we should not start with the drugs. Try all the other methods, start with education, psychotherapy, rehabilitation, and so on. And you have to talk to the patients. We don't have much evidence that any drugs are effective for nociplastic pain. And, oops, well, it is not here. Don't use strong opioids. If you have a patient with nociplastic pain, it is not good to start with strong opioids, maybe tramadol. And we have to keep in mind that most of the pain is mixed. But still, don't use strong opioids. Take-home messages. Well, chronic pain is common. Around 20% of people in Slovenia and in other countries in Europe have chronic pain, report chronic pain. And we should treat the patient and not just the pain. Sometimes the pain is going from 8 to 6 and the patient will be satisfied because when the pain was 8 on a numeric rating scale, he couldn't do anything. With 6, he's active. And if you think, well, it's just 2 points, but if the patient is satisfied, why not? In addition to standard methods of relief, we also have other non-pharmacological treatments. Use them if they are available in your environment. Multimodal treatment and multidisciplinary treatment is also very, very good for very difficult patients. And don't remember that one size fits all is not a good option. We have to talk to the patients, we have to listen to him. There are some patients who, if you say to him, I'd like to try with acupuncture, he will say, no, doctor, I don't believe in acupuncture. You won't have good results. Or vice versa, if you will say, I'll give you nerve blocks. No, doctor, please, I would like to try with acupuncture. And I think we have to listen to the patient. So our aim is to deliver the right drug or the right intervention to the right individual at the right time. If we are so smart, then we will be successful. Thank you.